Welcome to the Deep Dive, your shortcut to critical knowledge. Today, we are really undertaking a deep dive in something absolutely foundational for safe and effective patient care, patient education, and drug therapy.
hmm
We've pulled out the key insights from Chapter 7 of the Canadian Pharmacology text. If you're a healthcare professional, this information, well, it's basically the engine driving quality practice.
That's absolutely right. And our mission today isn't just to, skim the chapter. It's really to get into why patient education is called out as an essential nursing practice standard.
Okay.
We need to zero in on how nurses actually go beyond just giving information
Yeah.
to systematically empowering patients. We'll break down that framework, how the nursing process applies directly to teaching, and really focus on those learning barriers that can, well, mess up treatment adherence.
Right. And I think the core idea, the thing that really jumps out from this chapter is that patient education shifts the patient. They go from just passively receiving care to being an active participant, really an advocate for their own health.
Yeah.
And if we don't get that right, safety and quality, they definitely suffer.
And to make sure that transition happens successfully, we have to start with the basics, how people actually learn and remember things. So we're going to use the three domains of learning as our structure and then trace that through the teaching process itself.
Okay, let's unpack this then. Let's start right there with the foundational theory. Those three domains of learning. We know they're cognitive, affective, and psychomotor, but how does actually using all three make a clinical difference?
Well, the difference is holistic adherence. It really is. If you only teach the facts, the cognitive stuff, you're missing a huge piece of the puzzle.
All right.
The cognitive domain, that's usually where we start. It's the thinking domain, basically acquiring and storing knowledge. But what's interesting is that learning isn't just static recall.
No.
It needs to move beyond just, say, repeating a drug dose. It has to get to higher level stuff like critical thinking, making decisions when they face a minor side effect, that kind of thing.
But isn't the hardest part often the emotional side? That, fear of side effects or maybe just not believing the drug will even work.
You've hit on the affective domain exactly. And the source calls this one the most intangible. It's all about feelings, beliefs, values, and critically, trust.
Trust, yeah.
So for the nurse, this means you absolutely have to be non-judgmental. You need to listen actively, maybe even for what the patient isn't saying out loud. Pick up on nonverbal cues. If you haven't built that trust and positively influenced their attitude towards the treatment, the facts just won't stick.
And then finally, making sure they can actually do the thing you're teaching them, like giving an injection.
That's the psychomotor domain, the doing domain. It's crucial for procedures like insulin injections, using an inhaler, you name it. And the only way to know they've learned it is through a return demonstration.
You have to see it.
You have to see them do it step by step. No assumptions allowed.
Okay, so now we shift into applying this, which naturally starts with assessment. You've got to know your learner. And the source lists a ton of data points we need before we even start talking about the drug therapy itself.
It's a really comprehensive assessment. You're pulling together general things like age, education level, emotional state, their environment, family support, but also very health-specific things.
Mm-hmm.
We need to know about any misinformation they might have picked up, all their current meds, including over-the-counters and natural health products, and crucially, their past track record with adherence. We're basically trying to predict potential roadblocks.
And the source really highlights two massive obstacles, health literacy and cultural background. I have to say, that section on health literacy was, well, kind of shocking.
It really is shocking, and it's something we absolutely need to address head on. That statistic, 60% of Canadian adults and an incredible 88% of older adults have trouble understanding health information. That's huge. And that difficulty isn't just an abstract problem. It directly links to non-adherence, to worsening disease complications, like with type 2 diabetes. It's not about intelligence. It's about their ability to navigate complex medical jargon, often when they're already stressed.
And that need for sensitivity for understanding where the patient is coming from leads right into the cultural assessment piece. The source specifically mentions the importance of understanding Indigenous peoples of Canada First Nations, Métis, Inuit especially, considering the history of colonization and its impact on traditional healing.
Yes, providing respectful, truly individualized care is paramount. The source talks about the value placed on elders and the medicine wheel, which is such a powerful concept representing the four aspects of health: spiritual, mental, physical, and emotional, all in balance.
Right.
So for a nurse, this means understanding that just handing someone a prescription might not be enough. The physical drug regimen needs to, at the very least, respect and ideally integrate with the patient's existing spiritual and emotional framework. If it doesn't, adherence is likely going to suffer.
And development stage matters too, right? Like using Erikson's stages of development. How you teach a toddler who's working on autonomy versus shame is completely different from teaching an older adult focused on integrity versus despair.
Absolutely. The teaching approach has to align with their current developmental focus. And, we also can't forget the immediate, sometimes temporary hurdles.
Like pain.
Exactly. Pain, nausea, severe anxiety.
Yeah.
You simply can't conduct effective teaching when someone's actively distressed. Those immediate physical and emotional needs have to be managed first, period.
So we've assessed the patient, identified potential barriers. Now we get to the diagnosis phase. And this
Uh-huh.
seems crucial, deciding if the barrier is about ability or about choice. The source makes a key distinction here.
Yes, this distinction is clinically pivotal. It really changes your whole approach. We use the diagnosis inadequate knowledge when the patient genuinely has a limited understanding or skill set. They can't do it correctly because they don't get the mechanism or they haven't mastered the psychomotor skill, like using the device.
Okay, that makes sense. But what if they do understand it perfectly, they can physically do it, but they're still not taking the medication?
That's not adherence. This is where the patient actively chooses not to take the drug as prescribed. And this isn't just playing with words. Diagnosing non-adherence means we have to dig deeper. Are there physical reasons, emotional barriers, socioeconomic factors, like cost?
Right.
If they can't afford the copay, or they fundamentally don't believe the drug is necessary despite understanding it, then simply repeating the teaching plan won't help. You need to address the affordability crisis or the belief system.
Got it. So once we have the right diagnosis, we move into planning. This
Yeah.
is about setting mutual goals and clear, measurable outcome criteria. And those outcomes need to be realistic and, importantly, patient-centered.
Yes, absolutely mutual.
Yeah.
So, for example, let's say the diagnosis is readiness for enhanced knowledge, maybe for someone starting a new oral anti-hyperglycemic drug.
Yeah.
A sample goal could be something like the patient safely self-administers the prescribed drug within, say, 1 week. But making that goal truly mutual means negotiating, especially with complex regimens they might be on for life. It has to work for them.
And the outcome has to be something you can actually measure, something objective.
Precisely.
Yeah.
So a good sample outcome criterion tied to that goal might be the patient remains without signs or symptoms of overmedication while taking the drug. And you'd list specific measurable signs of hypoglycemia like tachycardia, palpitations, sweating, hunger, fatigue. Those are the concrete things we can evaluate.
Okay, now implementation, the actual teaching part. We've assessed, diagnosed, planned, now we deliver. And this is where it gets really interesting, especially tackling that huge challenge of low health literacy we talked about.
Accessibility becomes the absolute priority here. The research is pretty clear. Written materials generally need to be at a grade 8 reading level or even lower, and available in multiple languages.
Yeah.
It's kind of humbling to realize that we as professionals often communicate at a level that statistically maybe 60% of adults struggle with.
So just handing over a pamphlet isn't enough. We need other strategies.
Way beyond just text. We need repetition. We need audiovisual aids, videos, pictures. We definitely need demonstrations for anything hands-on. And we should use aids, both low-tech, like medication calendars and pill organizers, and even the high-tech stuff the source mentions, like those ingestible sensors that track if a pill was actually taken. We need a whole toolkit.
Let's touch on language barriers again. The source is quite firm on this.
It's critical. Prioritize communicating in the patient's preferred language whenever possible. And while English and French are major needs in Canada, the source points out the growing demand for materials in Southeast Asian and East Asian languages too. But here's the really crucial part. Avoid using family members as translators if you can possibly help it.
Why is that so strongly emphasized? It seems like the easiest option sometimes.
It might seem easy, but the risks are significant. Bias, whether intentional or not. Misinterpretation, maybe they simplify complex instructions or omit side effects they deem unimportant. And major confidentiality breaches. A trained professional interpreter is always the safest practice.
Right, that makes sense. And implementation isn't just a one-off thing before discharge, is it? It starts right away.
Absolutely. Start teaching upon admission. Keep sessions short, focused. Minimize distractions, turn off the TV. Ask visitors to step out for a few minutes. And use positive reinforcement, especially with kids. But adults appreciate it too. Just acknowledging their effort goes a long way.
Okay, which brings us to the final step, evaluation. How do we know if any of this actually worked? The source calls this critical for safety.
It is absolutely critical. We need to verify learning occurred and the gold standard method mentioned.
The teach-back method.
That's the one. You ask the patient to repeat the key information back to you, but in their own words. Or, for skills, you have them perform that return demonstration.
See it again? See it again. Ultimately, successful behavior meaning consistent adherence and proper management of their medication at home. That's the true measure of successful teaching. And the source stresses, legally and ethically, starting teaching early, minimizing distractions, and always, always using teach-back before discharge is the safest approach. So wrapping this all up, what's the big takeaway? Patient education isn't just an event, it's a continuous process. It demands a holistic view, looking at cultural values, literacy levels, developmental stage, not just the drug facts. And maybe the most critical clinical skill here is figuring out if you're dealing with a knowledge gap or a choice-based non-adherence. They need totally different solutions. Yeah, definitely. And looking back, those three domains, cognitive for thinking, affective for feeling and believing, and psychomotor for doing, they're all essential. But the whole process hinges on tailoring it to the individual, making sure materials are accessible, especially hitting that grade 8 reading level target.
Right. This deep dive really underscores that nurses are fundamentally teachers and patient advocates. Now, we mentioned earlier how the source talks about technology like ingestible sensors and tracking apps.
Yeah.
That brings up a really interesting point for you, our listener, to think about. What kind of ethical challenges or even practical hurdles might we face down the road when a patient's medication adherence or non-adherence could be automatically tracked by smart technology and maybe reported back to healthcare providers, perhaps without the patient fully grasping how that data is used?
Wow, that's a really thought-provoking question for the future of practice. A lot to consider there. Thank you for joining us for this deep dive into patient education and drug therapy.